after we started this project, we've done training of our clinical teams, right from the primary healthcare facilities all the way to the referral facilities. So now we are having better diagnostic capacity as well as screening.
So currently we have the correct guidelines on how to handle other chronic lung diseases like asthma, COPD, and also for cancer we have the right guidelines. So we are able to manage TB as TB and other chronic lung diseases as other chronic lung diseases.
And even shows you the session is complete, so acceptable AA.
Also, even as we look at a supervision of when we go to facilities, that has also changed. We are encouraging facilities, including the administrators and the managers, that when we screen, we are not screening for just TB. We want to be able to look at it. What does the patient have?
And in doing so, we are able to now limit the misdiagnosis that we've been having, and also to have accurate diagnosis, early diagnosis with the screening, and of course improved patient outcomes at the end of the day.
We have been doing integrated lung health outreaches as opposed to previously what we were doing. We are able to screen for TB, screen for other lung chronic respiratory diseases, and be able to offer a direction as a one point or a one area, one-stop shop for chronic respiratory diseases.
This project has really brought a difference, especially in the lives of our community. The need is so huge at the community level that in one of the outreaches we were able to net 16 TB cases, 26 asthma cases, and 36 COPD cases.
The outreach we had in industrial area prison, we are able to screen almost all the inmates who were there, and we are able to pick TB. We are able to pick how many asthmas were there. We are able to pick the COPDs, and now we have a picture of our prison, how things are. So we are integrating TB in lung health, and we are looking for everything wholesomely, holistically for these clients.
We've so far done 802 spirometers, and 84% of the done had either asthma or COPD. That has clearly indicated that the need for our community is very high.
This approach has really been working with implementation phase started in June last year 2025, and so far when we look at the numbers, we have seen cases coming up. These are the cases that were missing before.
In terms of the TB case detection, there was an actual increase of 7.5%. And also the bacteriological confirmation for TB disease for all the TB cases notified from phase 1 counties has increased by 6%. And unlike before at the program level where we are just dealing with TB, through this effort we were able to notify over 80,000 cases of asthma, and we have that data in our system. We were able to notify about 1,200 cases of chronic obstructive pulmonary disease, and also post-TB lung conditions are picked about 425 cases.
Integration has made my work smarter. It is not actually heavier, because it has really reduced the number of visits for patients. That means less work for me and much help for the patient. So it's a smart thing.
Our workload for lung health assessment is really picking. Like in a month, as we started, we used to see around probably less than 10 or 15 cases in a month. But currently we are seeing to a tune of around 50-something cases that are attending our clinics. So our clinic is active day in, day out. We don't have a specific day. And we are seeing these cases coming back to us to request to be done the spirometry. Wanasema puliza.
Some of our patients may go to may develop actually advanced lung damage because of TB or even other lung conditions, and such patients may require rehabilitation. So our rehabilitation approach is at the facility level and at the community level. So the empowerment of the community health promoters and all the community health actors at that level will be able to help in terms of the continuum of even pulmonary rehabilitation program within the community setting.
the CHPs are well sensitized on the signs and symptoms, and as they go to the household, they are able to identify this patient or this household needs to be referred to the facility.
Currently, we refer them using the referral forms, which is being standardized countrywide.
Tuko na kitabu inaitwa MOH 100 referral book yenye huwa hatukosi, tunatumianga kurifaa mgonjwa kwa daktari.
I have a lady known as Kerubo. Kerubo is a 30 years old. She got ill when she was 11 years for TB treatment. She was cured, but still, she didn't finish her problem in her body or her chest. When I identified her in my household, I gave her health talk about spirometry, about 6 minutes walk.
Idris Chefchi ilikuwa ananisaidia advice. Vumilia, nitakushughulikia bila nitakutafutia daktari na upatikane ugonjwa. Usijaribu kufikiria mbaya. Nitasimama na wewe. Na ni ukweli akasimama na mimi. Akakuja kaniambia nipe siku 3. Kuna kipimo kinakuja mpya. Nitakuja kukuita tuangalie shida iko wapi. Ukweli alikuja hadi kwa nyumba. Kuja akaniita. Kanileta hadi huko. Daktari wangu akaniweka pale kwa laini after sekondi 5. Karudi kwake. Ndio nirudi kwake akanipima na ile kipimo ya masini. Ugonjwa kaonekana. Ugonjwa ulikuwa ni shida mbavu moja ndio ilikuwa na shida. So nilikuwa nahangaika sana.
What I normally screen beyond TB, first, wheezing. When somebody wheezes, I believe that is a sign and symptoms beyond TB.
Zingine huwa ninawauliza, hiyo umekuwa ukikohoa? Yes. Kikohozi yako iko na damu? Hata kama haina damu, ni vizuri ukuje hospitalini uangaliwe.
Tunawaambia pia mambo ya pollution. So tunawaambia mostly unaweza pata hiyo shida ya kifua kulingana na kwenye unafanya kazi. Labda unafanya kazi kwa kampuni, hiyo chemical inatumika kwa hiyo kampuni inaweza kuaffect.
Nilikuwa nafanya kazi kwa maua, ndio sasa nikagonjeka, ilibidi mpaka niachie hiyo kazi. Venye nilikuja na nikaona hii treatment inasaidia. For the time nilikuwa nakuja si kupata hii treatment hapa. Na wakati walipokuja walinisaidia sana kupima hizo vitu. So wanasaidia watu. Juu kama isipokuwa ni wao, I think singejua venye niko na singejua ugonjwa yenye nilikuwa naugua nayo.
Katika community pia tumepata kuwasaidia wengi, especially wakati labda kuna mikutano ya baraza za chief, tunajaribu kuelimisha na kuelezea mambo kuhusu mambo ya lung health, kwa kuwa wengi walikuwa nadhania tu ni mambo na TB na mpaka wanaogopa kuja hospitali, na mara nyingi wengi pia wanakuja wakiwa chini sana, wanabebwa, they are bedridden, wengine ni kusaidiwa tu, na anapofika mahali hapa anapatikana labda sio TB, it's something else kama asthma, COPD, vitu kama hizo.
Nilipata mafunzo na nikajikubali mimi mwenyewe niko na shida ya kifua na hiyo shida zingine. Nilielimishwa kupata hewa safi na kukosa kutumia jiko kwa nyumba. Kuna kuwa wanasema iko carbon, mimi I don't know, lakini nikitumia hiyo jiko saa hii kuna venye naanza kusikia hadi kichwa, nikaachana nayo. So nika prefer cooking kwa open air.
Also, we want to sensitize the community leaders, like church leaders, so that during church services, they can deliver the messages. Also, we sensitize the school teachers so that they can give information to the pupils or the students.
So one of the major issues we are having is the issue of capacity building. in terms of you get a healthcare worker trained today. The site you had chosen, they transfer to another site, so you need to keep on educating and rather giving health education to these healthcare workers to be able to continue with the work or do the mentorship.
Very few have been trained in terms of taking care of the spirometry or doing the actual test with the spirometry, so it is also a gap that we would need filled to have quite a number of our healthcare workers can be able to take on the test and be able to do it.
So for Madhya, being a peripheral sub-county, some of the challenges that we've had, access to the tools like spirometry and a peak flow meter, and also the chest x-ray, the CT scans. But for the basics, if you were to get the basics like the peak flow meter at the lower facility levels, it would cut the need to refer all patients to come at the main facility for the various tests.
So probably a challenge for us or a barrier for us to scaling up of these services in our sub-county is one thing is the fastness of the sub-county.
So the biggest barrier I would say is staff turnovers. We have transfers every now and then. And the other thing they are complaining that we need to integrate the TIBU and the Afya KE because they are complaining it's a challenge to shift from one system to the other. But I know it's in the process and we'll be very happy.
Another challenge is the commodities at time. Like for now, you can see one patient can use some mouthpiece for the spirometry, 2 tubes. Then the nebulization thing, the mask, at time they are out of stock. We have to source them and the facility has to buy them.
And if you see, the lung health commodities is not a very expanded area, so we don't have as many facilities having maybe, for example, ICS, the inhaled corticosteroids, or even the inhalers, or even smoking cessation programs, or even pulmonary rehabilitation services. We do not have such services as much. So despite the challenges that we're having, I would still say this is the right direction and this is the way to go, and I would hope this can be scaled up even to other counties so that we're able to answer the question, if it is not TB, then what it is, and how we can be able to evaluate that and how we can be able to manage.
Phase 1 did not focus on national coverage. It chased proof. The question isn't whether this works, it's how fast it should move.